So can everybody see that presentation? Put your hand up if you can't. This is no, I'm going to take you. This is a bit of chat from me, and it's going to take a little while, but hopefully it's informative and hopefully it's even entertaining. I hope so, anyway. But I really want people to have a really good understanding, because I know there's some people who haven't even heard of Safewards. So I want people to have a really good understanding of what Safewards is, and also why we're kind of taking it onto your younger adult wards. So, and we'll come to this actual poster. This is a poster from an actual a younger person's ward that's doing Safewards. That's in Perth. Today's agenda. It'd be nice. I'm just going to go through who's in the room, because we have 15 organisations. We're taking it on to 20 younger young person's ward, but we've got 15 actual organisations. I'm going to go through what Safewards is. I'm going to take you through what we know about Safewards in younger people, what the project's going to do. Then we'll have a little chat about your role. Then we'll have a breakout rooms where you'll have a chance to ask questions, and we've got some questions that we'd like you to consider. And then we'll just think about the next steps and resources as we progress. The project is starting proper because we've just recruited the project workers. So this is a chance for us to really sort of interface with you and start the whole process of getting to know you and hopefully assisting you. I'm going to kick off proper. As I said, as I go through this, any questions, then please do post them in the chat and we will try and answer them. I'm going to tell you what is Safewards. The first thing to say about Safewards is that it is evidence-based. There was everything that around Safewards actually comes from research. Led by Len Bowers, but also assisted by people like Alan Simpson, actually. And the biggest piece of research that was done around Safewards was a randomized control trial, which cost about £6 million, and that was in 2013. So it is very solidly evidence-based. And the evidence shows that the Safewards interventions, the interventions I'm going to show you, reduce what we call conflict and containment. And as you'll see, containment is really restrictive practices. It reduces conflict. In the randomized control trial, it reduced conflict, patient conflict, by about 15%. And it reduced containment by staff by 24%. We've had numerous other studies which kind of added to that evidence base. We've had very few dissenting studies that say that it doesn't work. In fact, the majorities of studies say, yes, Safewards is effective and it does reduce conflict and containment. And there's the latest one that we've had, which is a replication of the trial that was done in Australia, in New South Wales. But we also have studies in Denmark, Finland, and Germany that kind of support the Safewards evidence. So it's very solidly evidence-based, but I'm sure, and if people are interested, I will send all the papers about the evidence-based, but today is very much a practical what is it, rather than going through the nuts and bolts of the evidence. But I just wanted to make sure that people are very clear it is evidence-based and it's in multiple places. It's so evidence-based, it's actually in NICE, the Violence and Aggression Short-Term Management in Mental Health in the Community. In their guidance, if you dip into the evidence from which the guidance comes from, you will see them saying that Safewards has a moderate quality evidence, which for NICE, to be quite honest, I'm quite pleased with that. That'll do. NICE are very, very hard taskmasters. That is grand. But I just want you to also notice that they say Safewards implementation requires minimal training. I would actually say it requires no training, but minimal training will do. That's fine. It actually is something that's very much people can use off the shelf. There's not a huge ask in terms of training staff up. And as you'll see, many of the interventions and indeed the thinking is very much within the mindset of any qualified professional, or indeed anybody who works in kind of the areas that we're going to talk about. So it's an intervention that requires minimal kind of a minimal effort in terms of training, but then has an impact in terms of reducing conflicts and containment, and even NICE say it. But more importantly than NICE for me is the dear old CQC, who also have kind of said that they've seen positive kind of impact of Safewards. And this is a quote from their 2017 State of Care report. And yeah, it's lovely. They went on to a ward. The ward had changed because they were using Safewards. But the bit for me that's really important within this, both within Safewards and probably even this presentation, is the bit in yellow. that the success was due to the genuine staff engagement and buy-in to the ideas of using Safewards techniques all the time, not because somebody told staff to do it, but because they believed in it. Because I think Safewards really is something that staff have adopted because they can see the value in it, but also it kind of it's something that they you know, they recognize the interventions and they recognize the thinking behind it, and it's something that they genuinely kind of want to put into practice. So that's kind of music to our ears in a way. And the dear old CQC saying it is very nice, because you like the CQC to say nice things, because they're very powerful and very important. Before we go on, and I'm going to take you through exactly what Safewards is now, I just wanted to clarify some terms. Safewards, and I want to be absolutely upfront, Safewards in its original form and everything I've talked about today was actually designed for younger adult acute inpatient wards. So that's the kind of 18 to 60 kind of general acute wards and PICUs. And we didn't talk about reducing restrictive practices. We talk about conflict and containment, and we want to see conflict and containment reduced. But there are huge parallels, as you'll see, between containment and restrictive practices. But I actually say reducing restrictive practices is a very negative term. It's loaded with negativity. And what I always talk about is we're talking about increasing safety. That we want to increase safety, which I think is a much more positive way of looking at it. And it's the safety of the whole population, both the staff and the patients. As a big expert by experience in Australia, Indigo Dea says it, Safewards is about the safety of everybody, and you can't keep everybody safe until everybody's safe, and we're very much in that. This is about staff and patients together, not just what staff do to patients. And that's what the logo actually means. The logo is representing the two communities on a ward, the staff group and the patient group, and kind of harmony between them. Okay, Safewards proper, conflict and containment. Been chucking those two words around, so we probably just need to put some definition on them. Conflict and containment are essentially two sets of behaviours. Conflict is a set of behaviours that on younger adult wards we see demonstrated by patients, and containment is a set of behaviours that we see demonstrated by staff. With this audience, I'm not going to go into huge detail. The only thing I would draw your attention, well, there's two things I would draw your attention to. The first one is where we say special observation and containment. That's kind of one-to-one constant eyesight observation. General observation 15-minute checks are not included in that, because we believe those are very positive interventions actually. And I would say that when we look at the conflict set of behaviours by patients, let's not think bad patients. There's very good reasons why patients abscond. There's very good reasons why patients refuse medication. But the thing that unites both of these sets of behaviours is that they cause harm to somebody somewhere in the system. And the harm there for the patients is not that they go off and harm somebody, but those groups of patients, so patients who refuse medications or patients that abscond, have less positive outcomes that patients don't. So they're more likely to have the containment behaviours used against them. They're more likely to stay in hospital longer. And there's some evidence that they're more likely to get higher doses of medication. So there are negative consequences for those groups. So what we're interested here is, because these two sets of behaviours cause harm, what we're interested in Safewards is understanding them first of all, and then seeing if we can reduce them. Is there anything, and as I've already said, the interventions have been shown to do that. But that, well, right at the start, we didn't know that. So what we were interested in doing is, can we understand these sets of behaviours on wards? Can we kind of have a mind map of why they happen on younger adult wards? And then from that, could we then develop some interventions that could change it? And we've been successful in that. So the first thing then is to talk about that mind map. Can we understand them a bit better? And the Safewards model, or the kind of the research synthesis to make Safewards into a model, is actually, somebody's microphone's just gone, is actually quite complicated. There's a technical, oops, somebody's microphone is, thank you. Sorry, so we're interested in understanding those conflict behaviors so that we can change it. And for 20 years, the kind of Len Bowers was looking at this, and Safewards kind of the iteration, the kind of final, if you like, the final thinking around that kind of the synthesis of that 20 years of thinking. And we see conflict and containment. There are the things we've just been talking about over on the right-hand side. And the first thing to notice is that double-headed arrow, which is very important, because the way this is written, it's kind of like we have patient conflict and that leads to staff containment. And yes, that happens. But what we also need to realize is that containment itself, the things that staff do, can also generate conflict. The simplest way to demonstrate that is that most of our younger adult wards these days are locked. And if we say, why are they locked? One of the reasons is to try and reduce the amount of absconding. And you know, if we put that up, you know, one of the reasons wards are locked is because we try and reduce absconding. If we look at that, does it actually reduce absconding? Actually, it does by a short percent. But we can also see behaviors that increase if the doors are locked. And those particularly, we can see increases in aggression and increases in self-harm. So there we have a containment behavior where we've locked the door, and what we're actually generating is more conflict behaviors, more self-harm and more aggression. All of that doesn't mean to say we open doors. All this is trying to do is understand. It's trying to make sense of a very kind of complex system. So conflict and containment, think of them probably as kind of symbiotic kind of happening together. If you want a picture of them, I always think of those cartoons with two kids fighting where it's just a big ball of dust and all you see is arms and legs coming out. That's kind of what they're like. They're kind of over there acting in tandem together. So that's over on the right-hand side. But the Safewards model kind of takes us to them. It's very interested in what's the process by which we end up with conflict and containment. So if we go back across to the far left to the far right, horizontally, is kind of like the dynamic process by which we end up with conflict and containment. And we start with originating domains. And all originating domain says is that an inpatient ward is a unique place in society. It's absolutely unique. You know, its function, its role, the staff, the patients, the how it's organized, even the law, even things like the Mental Health Act make it this unique place. And from that uniqueness, we have what we call originating domains. Now, these are generators of flashpoints. So there's aspects of the ward that are throwing up flashpoints. And flashpoints are probably the most important part of this model, because flashpoints are situations coming from the originating domains where members of the community, usually staff and patient, but it can be patient and patient, are going to come together. They're going to have to resolve some difficulty or some tension, psychological or practical, that's arisen from the originating domains. And what the model postulates is that these flashpoints are happening all the time. And it's the way in which they are managed by both the staff and the patients, but increases or decreases the possibility of conflict and containment. So we're talking in a way about probabilities. We have the originating domains throwing up flashpoints, and the way in which they're managed, if they're managed well, conflict and containment will go down. And if they're managed less well, conflict and containment kind of goes up. So originating domains throwing up flashpoints, the way they're managed dictates, if you like, the final rate of conflict and containment. There's other things that influence conflict and containment, but those are big factors. The reason staff modifiers is above the patient modifiers is that staff have more power. Staff have power in this environment. We control this environment. But both staff and patients have choices all the way along this model, and they can affect the rates of conflict and containment. Now, I keep saying staff and staff can affect. We actually have research evidence to say that that rates of conflict and containment are actually ward specific. That, you know, if you went into a hospital, let's say, and you had 4 wards all beside each other, all younger adult, all roughly the same amount of beds, that if you did longitude, if you measured their rates of conflict and containment over long periods of time, you are likely to find a struggling ward that has much higher rates of conflict and containment than the wards around them. And that's been generated by the culture of the ward. In the worst cases, we have seen rates of 10 to 20 times higher over a long period of time. And those are studies like Tompkins Acute Ward Study and City 128 study. So this is all actually ward specific, you know, and I will say this because I've been a nurse for many years. If you'd come onto my ward and said, oh, you've got high rates of conflict and containment, I'd have blamed everybody else. You know, the government are useless, the trust won't give me an OT, or my patients are more difficult than the others, they have a PQ, my consultant's an idiot, whatever, you know. Or my consultant's brilliant, you know, if it was going down. But it would have been kind of, and all of those things actually have an element of truth. But ultimately, rates of conflict and containment are in the gift of the ward staff to decrease. And that's a very clear challenge that Safewards throws up. The other challenge that Safewards throws up is traditionally, on younger adult wards, when we've talked about conflict, we tend to talk about it like it's very much rooted in the patient illness. You know, the patients are very acute, therefore we have a lot of conflict. And again, there's an element of truth in that, but I just wanted to dip into the perhaps more complex. These are the originating domains. So if you think about that model we've just looked at, these are the originating domains that are throwing up flashpoints. And I'm not going to go through them in great detail. How the staff organize the ward, how they can throw up flashpoints. The physical environment for both the staff and the patient throws up flashpoints. I'm sure everybody who's worked on a ward understands that. Outside hospital these days, our wards are much more permeable, which is a really good thing. We're not, that's wonderful, but it brings with it issues with families and just issues with kind of real life. Patient community, I don't know how big your wards are, but basically it's really hard to share a space with other people, particularly if it's a lot of other people, and particularly if you're all struggling in some way to kind of deal with whatever you're trying to deal with. So we see issues in the patient group in terms of discord, and theft and other kinds of issues. And then 5, yes, patients come with a variety of internal things, symptoms, hallucinations, or internal battles that we are trying to help them and they're trying to manage. That's basically what a ward is about, is somebody can't be managed in the community. They've come in for us to try and get a real handle on what's going on for them and to treat them as best we can. The only reason it says young, male and abused is that we can see some of the rates. If you're a young man, you're more likely to abscond. If you've got a history of trauma or abuse, you're more likely to self-harm. Those aren't judgments. They're just obviously things that we all know from what patients come in with. And if all that wasn't enough, then you've got the regulatory framework, the Mental Health Act, the CQC, NICE, everybody, and the trust and policies that kind of tell patients and staff what they can and can't do. And obviously they have to manage that. The reason I'm showing this is to go back to that thing of, you know, we've often seen conflict as a root cause is the patient illness. What this would say is, yes, the patient illness does play a factor, but there's a lot of other factors, and that conflict actually is much more complex than that. There are many other factors that in the environment and in the culture and in how things are run that we need to take into consideration if we're truly to understand the rates of conflict and containment, and then obviously if we're truly to kind of address them and bring them down. I'm just going to show you the technical model, just to show I'm not lying. You can go on the website, you can see it, and it is fascinating. If you're interested in this, I think it is, but you know, I'm a bit of a nerd this way, and I appreciate not everybody's built that way, but it is really fascinating to see how the bits of research have mapped those originating domains and what flashpoints come up from it. But it is important just to kind of take on board those 2 challenges. Safewards is clear that ward staff and culture have an effect of conflict and containment, both positive and negative. Patient symptoms do have a bearing, but the model indicates it's not the only factor, and that often the conflict instance and indeed containment instance are a combination of other factors. But ultimately, the staff have power. There's power to drive down rates of conflict and containment on a unit. And the way to do that is to both consider and improve the patient experience. And what Safewards then kind of takes the next step and says, and we've got 10 interventions that we believed, and we now very much believe, do that. These are 10 structured interventions that will take you in that direction of reducing conflict and containment. I'm going to pause for a second. Anybody got any? Because I appreciate some people are coming to Safewards absolutely for the first time. So I just wanted to pause and see if there's any questions. And if there aren't, I'm going to move on. Okay. Okay, so that's Safewards. 20 years of thinking comes up with this. It looks very simple. You get into technical, it's much more complicated, but it does give us a direction to go to. It kind of indicates key things that we might be able to do. And the randomized control trial was actually about testing these interventions. It wasn't about testing the model, because these speak to the model. These are all designed to kind of affect that model in some way. And there are 10 interventions, and people often say, can you do 1 or 2? And we say, well, actually the evidence is about all 10. And we believe that culture change is actually complex. So we need, one intervention is not going to cover everything we're talking about. So we've designed these 10, and actually we trialed them and tested them, did all sorts of things before they hit the wards. And these are the 10 that people have been using since 2014. And I'm going to go through them. I'm just going to read them very quickly, and I'm going to spend a little bit more time with discharge messages to give you a bit more of a flavour of what they look like. But I'm going to run through them very, very quickly. Clear mutual expectations. We talked about staff and the patients and power, and staff do have power, and they should have power. You know, there's nothing wrong with that. But what we're looking with clear mutual expectations is to open up a conversation with our patient group. And the way in which we do this is that we get the staff to sit down and think, what are our expectations, behavioural expectations of how the patients should behave towards us, but also how we should behave towards the patients. What's the kind of, what can we promise? What's our kind of way in which we're going to organise the world? I always call this kind of the Northern Irish Peace Agreement, and it's probably a good way to think. Two communities trying to work out how to live together. And once the staff have done that, and there's advice on the webpage about how to do that, then they take it to the patients and they have a conversation and a negotiation, and the patients can input from their point of view, talk about what the ward looks like from their point of view, and that conversation goes on for as long as it needs to, but you end up with a list of expectations for both staff and patients that they can sign up to. These are our ward's clear mutual expectations. So a lot of wards talk about respect, but also practical things about, you know, still have to go into people's rooms. So, and each ward has to do that uniquely for itself, but they end up with a list of clear mutual expectations, and then new patients coming onto the ward will be given those. This is the expectation, but also new staff. You know, this is the expectation of us as staff. And also, you know, wards would pull it off the ward maybe at a community meeting once a month and say, how are we doing? You know, how are we all doing? Are we keeping to this? And once a year you pull it, or earlier, you pull it off and say, do we need to change anything? Have things changed? Do all of these still kind of sit with this community? So that's clear mutual expectations. The mutual help meeting, we talked about some of the difficulties in the patient community, but there's also very clearly a huge potential for patients to help each other. It's very clear in the research from patients that they very much value help that's given by the patient community. And we kind of always known that, but the mutual help meeting is a place that we want to really value that. The information around this on the website is actually written by other patients. There's a leaflet written by patients. And what we're looking for in this intervention is, first of all, to thank any patient who's positively contributing to the ward. So it starts off with a round of thanks. And that round of thanks is very, very important, that we actually take the time to notice patients doing good things, either for each other or for the ward. And we make sure in this meeting, as much as possible, we can acknowledge that and thank them. And then the meeting proceeds with news, suggestions and offers from the patient group about helping each other and the ward. It's usually a nice social meeting, coffee, biscuits, you know, and some of the younger adult wards who've taken us on have done some adaptations. The next two interventions, talk down and Safewards, are effectively nudges. These are trying to encourage staff to demonstrate the best possible behaviour around two particular sets of interventions. Talk down is essentially, it's de-escalation. De-escalation, all the research says, is fantastic. Good de-escalation. De-escalation that really, really does keep the patient in mind, makes a good engagement with the patient, even when they're aroused, and is able them, just through the power of communication, to take them from a position of arousal to a position of calmness without anybody getting hurt. It's wonderful. And we have some fantastic de-escalators out there in wards. So this is really recognizing just how good de-escalation is as a skill. And there's a little bit of internal reflection that we ask the ward to do in order to make sure that everybody gets their de-escalation as good as it can be, and that they're constantly thinking about how to make sure their de-escalation skills are functioning at the highest level they can. A lot of PMVA people have taken this on because they really value this intervention and have put it into their PMVA training, but this is for the ward. There's a very big poster and a nudge and kind of a way in which we ask the wards to reflect and improve on that de-escalation. Safewards is also about communication. One of the things that came up in the research was about 35% of conflict from a patient point of view is preceded by what they call, and what we call in the research, less than optimal staff communication. So it's where staff have ignored somebody, sometimes been rude, or sometimes just dismissed somebody out of hand, or even just in the ways they've communicated, it's triggered off something in the patient. So Safewards is over 300 small pieces of advice for staff to think about. And it's general politeness on the ward, but there's also very clearly from the patient point of view, 3 particular times we have to be very careful in how we communicate with patients. The first one is when we deny a patient a request. The second one is if we ask the patient to do something, particularly something they don't want to do. So, it's your depot and I need you to come in and have your injection, that kind of thing. And asking patients to stop doing something they're enjoying. So the soft words are 300 of those pieces of advice, and the ward staff are encouraged to pick the ones that are useful for them, to think about them, and then trying to put them into practice on their ward. Moving on, know each other. Patients very much value ordinary conversations with staff, conversations that do not make them feel like a patient. So conversations about Euro 20, about, Chelsea winning the Champions League, about their favorite book, about the weather, about their pets, about their kids, just ordinary conversations that between 2 people that don't make them feel like staff and patients. And we know that. So what we've done with Know Each Other, we've tried to create an icebreaker. So staff fill it in. It's neutral bits of information about them. So for me, it would be, I support Charlton Athletic. I don't like parsnips. I like cats, that kind of thing. And invite patients to I would be saying to patients, you can come and talk to me about any of these things if you like, if you support Charlton or support cats, or you just want to have a chat. We ask all the staff to do that, and we invite the patients to do it as well, because we want to generate conversation with them, and also we want to generate conversation between patients and patients. So that's Know Each Other. Calm down methods is a specific intervention for those days when patients are having a difficult day, and really trying to manage manage whatever is happening for them. And what we're looking for here is that we have a set of kit that's not medicalized. There's no medication or anything. This is just a box of ordinary things that they can come and ask to use to help themselves self-manage in those difficult moments. So it'll be stress balls, it'll be blankets, it'll be, in the trial we had things like aromatherapy hand oils, peppermint, we had herbal teas, we had postcards and stamps and envelopes, so if they wanted to write to themselves or somebody else, they could sit and write. We had sensory things where you could plug them in and make it into a sensory area. And the idea is that the patient comes along and they can take something away, they book it out and they use it. And I think the power of that intervention isn't actually in getting in the box, it's the staff offering it, staff having a conversation with them, the patient kind of being able to select for themselves what they want to try and use in that. The next 3, positive words, bad news mitigation and reassurance, are focused around the handover. They're focused around the staff handover, but they do different things. Positive words is, positive words comes about because if we're not careful, staff language during handover can actually be quite negative. Things like, oh, bloody hell, just another personality disorder. What are we expected to do? Or, well, what do you expect? He's a drug user. You can't trust drug users. That kind of thing. Now, what we're looking for in positive words is to draw attention to staff is we need to be very careful about how we talk about patients. So, and generally we wouldn't want to be stigmatizing or labeling kind of patients in a negative way. But in a handover, it's crucially important because we're handing over to a set of staff who are going to be on our ward for 7.5 hours. So we need to be very careful in the language we use, that we don't demean patients, but also leave them with a sense of positivity and a sense of hope. So we're asking in positive words that staff are very careful about their language, and that they hand over in a way that doesn't leave the other staff feeling demoralized, but also, and you can do that. You can hand over even challenging things in a way that doesn't blame the patient, but kind of understands the psychological reasons why patients do certain challenging things. That's positive words. Bad news mitigation and reassurance are 2 interventions that most wards, when you present it to them, say, oh, we already do this. And that's fine. And I think there's a high level of understanding about that. But the interventions are trying to make sure that we do it all the time and to the best that we can. Bad news mitigation just kind of sings to the fact that it's really hard to be admitted to an inpatient ward. It's really, really hard. And on top of that, patients often receive bad news from the outside the ward or even inside the ward, and that we see conflict and containment being generated by them trying to manage bad news. So we're looking to understand when patients receive bad news, and put things in place to support them. So I say this is in handover. So in handover, you'd see people saying, do we know of any patient that's received bad news in the previous shift? And are we anticipating that any patient will receive bad news in the shift to come, and can we plan around that? So, John's housing was precarious. There's been a meeting and sadly he's going to be evicted. The CPN's coming in to talk to him this afternoon about that and what his options are. That's bad news arriving for John with the CPN. So in this intervention, we'd say, okay, once the CPNs do that, we need to get in there and make sure that we can support John, maybe have a chat with the CPN beforehand just to say, should one of us go in? Should we be ready afterwards? Can we do anything to kind of help him? Because we can't take away the bad news, but we can certainly help him manage it. And then reassurance. Now, reassurance goes back to that conflict and containment being symbiotic. If bad stuff happens on the ward, if you restrain people, or if we're kind of having to force medicate people, or even just we're having an argument with somebody on the ward, the witnesses, the other patients around, are often left wondering what that was about. So reassurance is a commitment by the staff to say that if things happen on the ward, we will check with the patients that do they need reassurance? Do they need an explanation? What are the questions that they have? And it's very much looks the same way as bad news. So in handover, you would say, has anybody needed any reassurance this morning? Is there anything that we've needed to reassure somebody about? Is anybody looking for reassurance? And also, well, yes, John's just been admitted, something happened, it really upset. He went to his room, we went to reassure him. He was really upset and unsettled. Okay, we'll follow that up this afternoon. We'll make sure that somebody has some time to go back and make sure that that reassurance was effective, or does he need any more further reassurance? And that's how it would look. And then finally, number 10 interventions is discharge message. I just want to pause before I go into discharge message. And I would hope by now you can see why we say minimal training. These interventions are all, I believe, within the skill set of our inpatient ward staff, who, and I would say this, I think we've got the best set of staff we've ever had in terms of training and things. We haven't got enough numbers, and they've got all sorts of other pressures, but in terms of their skills, we have a highly skilled set of people, and that they would recognize these interventions and be able to put them into place without us having to do huge amounts of training. But I'm going to move on just to talk about discharge messages, which is the last one. And this is just because I've talked about the others. I wanted you to see one. I wanted you to actually physically have a look and connect with one. And I've chosen discharge messages just because it's the most visual. It's the most dramatic. Now, discharge messages although it's called discharge messages, the actual power of it, where we're trying to get the impact, is at admission. As I say, being admitted to younger adult inpatient ward is awful for the vast majority of people, no matter what we do. And we didn't create that. We can't control it. I worked on wards. People arrived in all sorts of state and all sorts of distress. And what had happened to them before they got to my ward was truly awful, whether it was in, their own internal stuff or the world and life. They often arrived with horrible, horrific stories. And I couldn't control that, but I can control what happens when they step over the threshold. And when they step over the threshold, what I want in that environment is for them to be able to partake in discharge messages. Because discharge messages, we actually ask patients when they're being discharged. So it's terribly difficult to be admitted, but by the time you leave, it's a very different picture. There's kind of, you've been through it. Hopefully you've been helped. Hopefully you feel like the ward's done some good for you. And we ask you at that moment to say, before you go, could you leave a little gift for people being admitted? You know what it's like. We don't. You've been admitted as a patient. We haven't. Could you give us anything? And we're looking for messages of hope, advice, or support for people who are being admitted. And if you do that, if you give us that gift, we will make sure that it's displayed and that it's treated with tremendous respect. This is a discharge message tree that we used in the trial. We had all sorts of fancy ideas about things. We turned up PICUs with this and they wouldn't let us in the door, as you can imagine. So there's lots of adaptions about how we actually do it. But I'm going to show you real world adaptions. And because we did trees, I think a lot of people then took on trees, and that's grand. This is, and you'll see this later, this is actually a younger person's ward. I just sort of chuck it in. And of course, we had places that didn't have many discharges, so they adapted it, and they have walls of hope. So these are messages of hope and advice and support from inside the community. And then people started to get clever. Yeah, trees, all the rest of it. So we had Harbour Ward, down in St Anne's in Dorset, and they decided that their discharge messages should be on a ship because they're sailing out of harbour. Yeah, I know. Anyway, so the discharge messages go in the waves. Not to be outdone, then we get wards like Cove Ward in Northampton. Now, Cove Ward decided we're Cove, so what we need is a lighthouse, and then the messages of hope go in the light beam. But my favourite, this is actually a 15 to 24 early intervention service in Rotterdam. So you haven't lost the ability to read English. This is actually in Dutch. But when they sat the young men down and said, right, lads, we're going to do discharge messages, trees, squirrels, they just went, we're young men. What we want is a getaway car. So they actually have their discharge messages on their getaway car, and the ward staff have printed off these pictures of Porsches and Lamborghinis, and I know nothing about cars, so if those words are correct, I'm very happy. So, and the young men, they put their messages on the Porsches and the Lamborghinis, and that's the artist that drew it. They were very specific. It has to be pointing away from the ward, ready for me to jump in the driving seat and drive away. This is all great fun. This is fantastic, and of course, it draws the eye and makes a patient being admitted, we hope, kind of interested in what's in there. But the power is actually in the messages. And these are real messages from real patients that I've picked off from Facebook and other places. So, I've improved in my mental health and became informal. I came in here on a section, I got off the section. Have faith things will get better, stick to your plan you've made, and keep in touch with friends. And staff very helpful, good days and bad. Chicken curry was lovely. And that's Mary Sheehan over in Ennis. On the website, you'll see us saying we don't want thank yous to staff, and we've had kickback from the patient group and good kickback saying these are our discharge messages. And actually, a patient to say you can trust the staff here is a very big message of hope and positivity. So we kind of backtracked on that because they're absolutely right. And as I say, it's very dramatic. This is something that's literally just gone up on the Facebook page from a younger adult ward in Perth, or a young person's ward over in Perth. And that is really quite stunning. And all the leaves have discharge messages on them. Okay, I'm gonna stop there for a second. Just say, has anybody got any questions about the interventions or any comments about the interventions? My feeling is things like the comfort box won't be that unfamiliar in a CAM service or a younger person, and some of the interventions might be more recognizable in your service perhaps than younger adult service, but that may be something we'll talk about in the breakout rooms. But I'd be interested in how those interventions sit with people. Okay, I'm going to move on. Any questions? Okay. We have seen adaptions, obviously, and I'm going to talk about the fact that it's been taken, Safewards has gone beyond younger adult wards. And before I talk about younger person services, it's been adopted now, because we finished the trial in 2014, it's now 2021, and it's exploded really. Len Barrs and I always talk about it, we're like holding on to the tail of a crazy horse. It's just going everywhere. And that's because it's free, it's organic, it's freely available. People don't need training. So people are just using it, and that's great. But we're trying to keep up with what's happened. So we've seen it in forensic, we've seen it in learning disabilities rehab, older adult specialist wards, in specialist personality disorder, mother and baby, and recently in eating disorders. So, and we're saying, does it work? Have you made adaptations? And we're trying to get our head around what adaptations people might have had to make it work in their service. And we have seen, we've got some information about that. So discharge messages, as I said, if there's not many discharges or people are not going to be discharged straight home, people do have to adapt to manage that. We've had lots of conversation about what you can have in a comfort box in a forensic setting, but there is a comfort box on a ward in Broadmoor. So, they've obviously got to the end of that and got some kind of you know, some agreement. A lot of visual know each other. As you remember the icebreaker for learning disabilities, and also second language issues. And the first people that generated that were actually people working with Aborigines in Aboriginal population in Australia. Aborigines are incredibly smart people. They have 400 languages, and English is right at the end. And they do a lot of things very visually. So, and some of the if you're from a dementia background or learning disabilities background, some of the interventions, like I say, you know each other. This is me, life story work in dementia. But we've had some really interesting adaptations that have taken it a bit further as well. So individual soft words where people ask patients, how should we talk to you when we have to, you know, ask you to do something you don't want to do, when we have to deny, what's the best way of talking to you in those issues. And what we have seen as it's gone into, particularly in dementia and indeed younger, and this is a big question for younger adult wards, is families and carers. Not such a big feature, not excluded in the younger adult wards, but a much bigger feature in the implementation in dementia wards and younger adult wards. So we're starting to see the adaptations. And I think the biggest, the most sophisticated area that's done that is the forensic and secure services. This is Tessa McGuire's work in Australia, who has mapped the kind of the adaptations. Safewards works, but it does need some tweaks and adaptations. And what she's done is she's very comprehensively mapped what those are and the explanations, and indeed the other flashpoints that they experience in secure, and some thinking around that. And this is going down very well. It's just about to be published, but it's gone down very well in, as I say, in our secure services here. And I know there's some secure services in this project. You're not just young people, it's secure. So we'll bring some of that thinking in to this. So what is Safewards? To end up to where we started, it's a model. The model we've seen, and the model has been recognizable, and we've had a lot of conversations, and it does seem to hold water. The model does seem to hold up. We'd like to do more research around some of the flashpoints, but that's not the important thing. I'm an implementer, not a researcher. I'm more interested in changing the world and understanding it. And the 10 core START interventions, they have a solid evidence base now in reducing conflict and containment, and that's expanded since the original RCT. But we call them the START interventions because once they're done, wards should kick off on their own, because wards never stop. Conflict and containment, we've only reduced conflict by 15% and containment by 25%. There's a lot more work to do, but the wards can then kind of take the thinking and generate their own kind of changes beyond the, once they've done the 10, we believe that they're well on the way to and a really good place to kind of kick off by themselves. Okay. I'm now going to talk about, it's just coming up to an hour in. I'm just going to talk about, very quickly go through, okay, but all the evidence is around younger adults. So what have we learned about Safewards in younger people services? Why are we taking this to you, given that the original RCT was around younger adult wards? I do find at this point, if you're asking a question like that, a general kind of position in life, it's always good to have in your back pocket is, in a situation like that, always blame the Aussies, because the Aussies have a lot to answer for. They have a lot to answer for in terms of Safewards, because the as you'll see as I've been talking about this, is they've really done a lot of very good work around Safewards and making it available for their services. But this is a Safewards information leaflet from the Royal Melbourne Hospital for their Banksia unit. We've got quite a bit of information about how Banksia have made Safewards work, because they've run Safewards now for 3 or 4 years, and in fact Origin have just employed a Banksia worker to take Safewards there. Well, that's one of the reasons he's gone there. He's quite brilliant as well. But the Victoria rollout really did expand from the original RCT. So after we finished the RCT, they put aside their insurance company and the Department of Health in Victoria. Len Bowers went and did a presentation there. They really saw the value, and they put a large amount of resource behind it. But they instantly took it beyond younger adults. They took it on the younger adult wards, but they also took it onto their secure wards, which is where Tessa's work comes from, their older adult wards, and their youth wards. and their youth basically is our care of young people. This is their children's wards. They in their rollout, they didn't replicate our RCT. Why should they? We'd already proved it worked. But what they wanted to do was just see if it was acceptable to the wards, and also if it had an effect on their biggest concern, their biggest restricted practice, which was seclusion. And there was a 36% reduction after their rollout, which was an 18-month rollout. But the biggest effect that they had, that they actually had their biggest effect in their youth services, which is great. But I'm going to show you, this is, we believe very much in honesty and Safewards, particularly if we talk about statistics. The reason they had the biggest effect in the youth services, as you can see by this graph, is because they started off with the highest rates of seclusion. The blue boxes are the pre, the red boxes are the post. But as a consequence, obviously, their reduction was dramatic. But I think from our point of view, their reduction was also, at the end of it all, they also had, the youth went to a lower rate of seclusion than their adult wards. And you can see with aged and secure that their original rates of seclusion were actually so low that you'd hardly notice it, really. So it's youth and adult, which were probably the two biggest ones that they could rely on the statistics with. But the youth, they reduced it by only half. Now, is that only Safewards? Probably not. There's probably other things going on. There's maybe we hit them at the right moment, but it's certainly a dramatic and very positive outcome, which is why they've then taken it on into their youth services. The Victoria rollout also looked at, is it acceptable? And it was. You know, what happened on their youth services was it was highly acceptable. The staff and the patients, they recognized the model and they recognized the interventions. They were able to put them. We would like a bit more information about how and why and what, but we didn't get that. But we just, yeah, they were acceptable, and they got a high level of fidelity, which is the measure of, is this intervention actually effective? And now they have it in Perth. The image at the start was an award in Perth, Queensland, Melbourne. And we also have it in Finland, Germany, Denmark. Since then, we've also seen evidence coming from Finland, their adolescent services. Germany, there's a small study in Finland using Essence, which shows that Safewards improves the therapeutic patient's view that the ward is therapeutic. We've got it in Denmark, and it's even started to creep out into places like youth justice services, and in fact in England, Care in Mind, which is a set of children's homes and eating disorders, in liaison with Len, they've taken it on as one of their core models, and they are saying, we're trying to talk to them about what have you done differently, what have you had to adapt, but they are very clear that it's had a very positive effect in their incidents are going down. So and they post a lot on Facebook, and again, the fidelity is very high. We've kind of looked at that, and they've even started to kind of take it into individual. Safewards is a community intervention, but they've started to take it into individual treatment of individual patients, looking at what helps them in terms of soft words, what helps them in terms of calm down methods, trying to get the young people themselves, their young people to help them understand what will work. So we got that. We've got the kind of evidence from Victoria. We got these small studies. We've got people going, yeah, it works. Although we're going, yeah, brilliant, but tell us how. And we also got, you know, just completely in Facebook. We've got as much coming from younger adults now as we have from any other services. So we've got stuff from Perth. Again, this is great. A Manchester Junction 17 Pegasus ward, really, really good ward. We've also got Germany. This is the stuff that we see all the time coming up, and while we're kind of saying this is fantastic, but we need to understand why, people are just getting on and doing it, which is great. But what is very, very clear is every ward ends up looking a little bit different. Safewards is a unique intervention, and each ward does it completely uniquely. So Safewards in younger people, we do have evidence that it's effective. We have evidence it's effective. We have evidence that it's useful in reducing seclusion from the Victoria study. And we are gathering and just hearing a huge number of successful stories from many countries. And we're not getting dissenting voices. We're not getting voices saying, this doesn't work here, this doesn't work in our service, this is not applicable. We are getting some indication that maybe not all the interventions sit exactly the same way, but generally Safewards is very acceptable. So but we have questions. What is different? What needs to be adapted? We kind of want to understand in the same way as Tessa did with the secure services, and we're very open to saying, look, we understand there will need to be adaptations and changes. We're not Safewards has to fit the ward, not the ward fit Safewards. So, but we do want to advise people and to be able to understand a bit more. We do want to kind of ask those questions. So we come to, what is this project going to do? So we've got all that. We got Safewards. We got evidence that just organic, but also from research and evaluation that it's effective. So this project, what's it about? So we're going to support 20 wards, which are in your organisations, to implement or relaunch. Now, I'm very aware, and I won't go into, we're not going into each, but there's wards like Primrose in Signet, which has done Safewards. Priory has done a lot of Safewards. So we're quite, and Riverside in Avon and Wiltshire, Avon and Wiltshire has done a lot of Safewards. So there'll be organisations that have done no Safewards, and that's fine. It really is. If you're one of those, it's fine. But there's also organisations and maybe wards that have done Safewards before. So we're looking there to relaunch. So we're not going to go in and start from scratch. We're going to relaunch. We're going to kick it off and see if we can get it back on its feet. So the 20 wards we're going to implement from scratch. We're going to relaunch. And in that, to do that, we're going to provide focused information, planning and support over a 12-month period, because that's how long it takes. It's 12 to 18-month intervention. It's a marathon, not a sprint. And we're going to monitor and evaluate uptake, outcomes, and the adaptions. And what's very exciting about this project is we're not just taking into younger people's wards, we're taking into young people with learning disabilities, eating disorder, children's with Alder Hey, Dewey Jones. If you ever want an inspirational moment, look up the Dr. Dewey Jones, Alder Hey, look up his story, because he's a remarkable man. But I only say that because I only read it because part of this project. I was really quite taken by it. But anyway, that's a children's ward. That's a very young age group. So we're very interested to see how Safewards sits with that service, and obviously secure services. There are a couple of things that I want to just bring to your attention, that in all this experience of, and just implementation in general, there are certain things we know we must try and get in place if Safewards is to be acceptable. And I'm going to say this to you straight up front. We must get the ward managers. Ward managers are crucial in this. We must get ward managers behind Safewards. They don't have to do everything, but they have to be behind it. If ward managers aren't behind an intervention on a ward, it doesn't happen. They can appoint leads, they can do whatever, but the ward manager we want really signed up and understanding what they're signing up for. It's often framed as a nursing-centric intervention, Safewards, but in reality, it works best with a much wider MDT. Nurses are there 24/7, that's true, but we often have other staff. Occupational therapists are really important in Safewards. Psychologists are really important in Safewards. And although the medical staff don't have specific interventions, we would ask them, to do their know each other, to really perhaps pay attention to bad news mitigation things. So the more MDT involvement, the better. You can do it just with nurses, but it's much better if you can bring in other specialties, and it's really good if you can bring in the whole team. It really has an impact. Any implementation plan must put the ward in charge. This isn't a kind of a by 3 months you will do. It's very much we have to go in, negotiate with the ward staff, explain to them what we're trying to do, see which interventions they feel will fit best, and then kick off from there. And they must be in charge of that, because it's their environment, it's their responsibility, but also it's their credit. If you think back to that CQC thing, that ward did it the way they should have done it. None of us know how a ward should do it. All we can do is help them think through, and the implementation plan must be theirs. It has to be a gradual introduction. 10 interventions, it's an elephant. Don't eat the bloody thing all at once. Choose 1 or 2 and then move on from there, and gradually get to the 10th. And if there's one you're thinking, oh goodness, this is going to be really difficult, put it down the line. Start with stuff that's going to infuse you, going to get you going. Active engagement of staff and patients and carers. None of us, very few of us on this call, unless we're a ward manager, are going to do Safewards on a ward. We're going to be we're the support crew. They're going to do it. So we need to really think about how we can best engage them and use them, or the staff. But we can. Supportive management is big. It's big. It makes a big difference, and it makes things go a lot easier and a lot faster. But there is resistance. You might think, oh, there isn't. How could there be resistance to those 10 lovely interventions? Well, you know, these are it's a tough place, a ward, and the staff as a consequence they're lovely, but they're tough as well. So you do have to, you know, we do reassurance, we do bad news. You need to be able to sympathize that, but also challenge them and say, okay, let's ask the patients, do we do it all the time? Are we really good at this? Oh, thank you. My wife's bringing me in a coffee. Thank you. So yeah, so we need people to be able to do that. I think I've covered why it's so long, but I noticed this just in the themed review, and I thought I'd chuck it in there. Yeah, we are talking about culture change, so yeah, it takes a while, but you know, we've got 12 months. We've set aside that resource. We'll be with you for the 12 months. We're getting down to the kind of getting to the room bit now, where we're going to open it up and ask you questions. But I just thought it'd be worth going through who's going to do it. So you can see, as everything I said, right at the top of this, top of the pyramid, the ward staff and the young people themselves. These are the crucial people. You know, we can all talk about change agents, but the reality is they're the change agents. Those are the people that are going to change. We're going to help them, but those are the people that are being tasked with this change. And amongst them, we are going to recruit some Safewards leads. That can be a ward manager, but it can be other people as well, appointed by the ward manager. So those, the top of that, that's the important group. Underneath that is this call. So we've got the organisational leads, and I'm thinking a lot of that will be you, who will be taking it onto the wards. And the project workers, we have employed 5 project workers. Sorry, we've employed 4 project workers who will each do 5 wards. So they will, and they'll make those wards into communities of practice. So each of your ward will be in a cluster of 5, not a cluster of 20. And we will work with the project workers and the project workers will be the people that will be going into the wards, doing the instructing, doing the supporting with regular kind of meetings. Underneath that sits me. I am the clinical supervisor. I've got wide experience of introducing safe wards, both in the UK, but also I've assisted the wards in Australia, wards in Indonesia, and indeed I've got wards in Germany and other places, which doesn't mean to say I know anything. All I know is a lot of people who do know, and all I know is a lot of resources that I can offer to the important people on the wards. But I'll be here to kind of bolster out. Project lead is Professor Alan Simpson, and it's obviously backed up by NHSI workforce, Taz and Ollie, and indeed their regional kind of leads. And over here on the far right hand side, we do have, to keep us all honest, we have a wonderful project evaluator, Maddie Ellis, who will be kind of doing all the questioning and trying to see, are we actually doing what we want, and hopefully doing interviews and looking at kind of what we can do to adapt it. And we've also the project will have a steering group, which will be another kind of way to keep us honest and keep us on track. Now, I wanted to be very clear about this, because although we're talking about support, and support is really important, and that's the pathway, that's kind of like, and it, you know, we are all set to support your wards. This is a public project which has got a lot of interest. It's been posted on Safewards. People know about it. So there will be an aspect of monitoring. We will be, you know, there's an expectation here. So your wards are signed up for it. So people will be watching. We will have to report. We should as well. This is public money. So we're going to be reporting back progress and any difficulties as well. So there'll be communication up and down that pathway. But the aim of that communication is to keep us on track. We really, really want you to succeed. And of course, there's obviously a 2-way evaluation in the middle of all that, so that we can hear, not just find out what the wards are doing, but hear from them. We want to really pick the expertise of your organisation, your wards, and indeed you, as we go through this project.